Hans, thank you for that kind introduction. President Opeltz, Jeremy, members and guests of the Society, I'm both humbled and honored to receive the Medawar Prize. I have worked in beta cell replacement therapy for 4 decades, but it is really a collaborative effort, and I really accept this prize on behalf of the entire community that has worked in beta cell replacement therapy, too numerous to name. It's hard to know exactly which are notable contributions, but things that I'm proud of: one is founding International Pancreas Transplant Registry in 1980, forming living donor pancreas transplants beginning in 1977, and pushing pancreas transplant on non-uremic type 1 diabetic patients, and our findings on reversal of secondary complications with successful pancreas transplants. And islet transplants, we performed the first one in 1973. We have had ongoing laboratory studies on the immunobiology of islet transplantation. They're always running in parallel with clinical application. And then we opened a new field with islet autografts. The initial case done to really try to understand what was going on with islet allografts in the absence of immune suppression. A brief historical narrative is in order because there was at least 8 decades before I entered the field that attempts were made at beta cell replacement therapy, beginning with the serendipitous experiments of von Mering and Minkowski, Strasbourg, France in 1989, where pancreatectomized dogs, pancreatectomized in an attempt to induce enzyme deficiency to study digestion, were serendipitously found to be diabetic. They immediately switched their research to diabetes and trying to understand the disease. Well, over the next 40 years or so, evolved the concept. At the seat of the defect was a beta cell in the islets of Langerhans, but all this work came to a halt with the advent of the war. And it wasn't resurrected until after 1950 when pancreas transplant experiments again began to be done. This culminated in the first beta cell replacement therapy in humans in 1966 with Richard Lillehei and William Kelly performing the first pancreas transplant. Now, there had been an attempt earlier with sheep pancreas fragments implanted in 1896 in a type 1 diabetic to no avail. But immediately vascularized grafts did work. However, there was many complications, and the idea that we should have minimally invasive surgery with just the isolated islets was the dream of the beta cell replacement groups that arose around the world. Meanwhile, pancreas transplantation was resurrected in 1978, and in 1980 at a meeting in Lyon, France, the International Pancreas and Islet Transplant Registry was founded. The Islet Transplant Registry later split off to be handled at the University of Gießen, but the pancreas transplant, we knew what was going on. We could modify what we did based on data, and it fostered international cooperation. And I'm especially grateful to Angelica Grusner for the work she has done with the registry that made it so useful. The long-term mortality risk we found is less with pancreas transplants than on the waiting list in all categories in our analysis. Registries continue to provide useful data that influence decision making. Need to make sure not overinterpreted when all comorbidity is not included in the database. Pancreas transplants from related donors we did because the initial results in the pre-calcineurin inhibitor era showed very low graft survival rates, and we took the analogy that living donor transplants had much higher success rate with kidney transplants than did deceased donor grafts. Would that apply to pancreas? And indeed, it did, especially in the pancreas after kidney from the same donor. There we showed 80% long-term graft survival rate, which opposed in the pre-calcineurin inhibitor era was less than 20%. Included in the living donor transplants was our observation on twin-to-twin pancreas transplantation, where we did not use immunosuppression initially, that there was recurrence of disease with isletitis and selective beta cell destruction. And in follow-up biopsies, the pancreas itself remained intact, alpha cells remained intact, but beta cells were selectively destroyed. We also observed, besides the isletitis, in the isografts, we also observed it in allografts. So with T-cell infiltration in the islets and selective beta cell destruction, and this banished all doubt that type 1 diabetes mellitus was an autoimmune disease, and it meant that even for identical twin transplants, immunosuppression was necessary. But there's also recurrence in immunosuppressed allografts. So immunosuppression or allotolerance adequate to prevent rejection may not be able to adequate to support an amnestic autoimmune response. And we know now that recurrence occurs in approximately 5% of deceased donor grafts based on biopsy and islet cell antibody monitoring. So we finalized the concept that type 1 diabetes was an autoimmune disease, and self-tolerance restoration as well as allotolerance will be needed to obviate need for immunosuppression in pancreas transplants, or islet transplants for that matter. We also pushed the concept of pancreas transplantation in non-uremic type 1 diabetic patients with hypoglycemic unawareness and its attendant risks. Now, many had secondary complications pre-end stage, allowing study of the effect of pancreas transplantation on these outcomes. Quality of life improved in these patients. It was justified to do this, and the idea that beta cell replacement therapy should be done early in the course of disease rather than late by minimally invasive technique as possible. Reversal of secondary complications of diabetes also was observed in collaborative efforts with Mike Maurer and others. Here just showing that remodeling of the glomerulus could occur in the native kidney. It took a long time, but these lesions could reverse. We also observed the same in neuropathy and retinopathy, where sensory index here improved. Here just showing a biopsy of the skin. Yellow and green are the nerve endings, and here this shows a normal calf. Here's one of the diabetic pancreas transplant recipients with absence of the nerves, and a year later these nerves have been restored with a functioning graft. So we showed that secondary lesions of diabetes could be reversed. This preceded the diabetes control and complication trial. However, cyclosporin nephrotoxicity could offset the reversal that occurred in the kidney, and non-cyclosporin, non-calcium inhibitor regimens are needed so full potential beta cell replacement can be realized. The success rate led to large volume in all three categories: simultaneous pancreas kidney, pancreas after kidney, and pancreas transplant alone. We've now done over 2,000 pancreas transplants, and pancreas transplant outcomes improved over time. Quality of life has been improved. The secondary complications have been favorably influenced. Pancreas transplant has become standard therapy in uremic diabetics, and in our institution in non-uremics with hypoglycemic unawareness. Islet allotransplants with a single donor should replace pancreas transplants, and islet xenotransplants should replace both. Now, as far as the human islet transplant is concerned, as I mentioned, we performed the first one in 1973. We reported on our early series at this meeting in 1976, and we reported our efforts on both allografts and allografts. And the islet allografts was a minimally invasive, safe procedure, but did not reduce insulin independence. However, islet autografts were able to do so, showing that a good islet prep could be made. Single donor islet allografts now do induce insulin independence, but the future will be islet xenografts or stem cell transplants. An example of our immunobiology work, which was always ongoing, we were able to define what was important in inducing non-function or classic rejection of islet allografts, and this led to our first experiments, our first insulin independence in type 1 diabetics with islets from a single donor. We've refined the technique, and now we can consistently have insulin independence with single donor, even with marginal dose islet transplants with induction therapy. The induction therapy does matter here, showing that with potent induction therapy regimens, the islet allograft success rate in islet alone is as high as that with pancreas transplants alone, with 50% insulin independent rates at 5 years. So induction therapy is critical for good long-term results with islet allografts, and single donor islet allografts are possible. We should be constantly testing new immunosuppressive protocols. Should be able to do single donor islet allografts with as few as 5,000 islet equivalents per kilogram. Now, as far as the autografts are concerned, the number exceeds that of islet allografts. We have reported serially on our islet autograft experience. We reported it at the meeting in Sydney, and we showed much greater durability of islet autografts as far as function is concerned, as far as insulin independence is concerned, as compared to islet allografts. This is one would expect in the absence of an immune response, but it shows what could be achieved with islet allografts if we can duplicate some of the factors that occurred with the islet allografts. We've now done more than 400 islet autografts since 1977. 1/3 are insulin independent. It's greater than 80% of more than 5,000 islet equivalents per kilogram are transplanted. 1/3 are euglycemic and once daily long-acting insulin, and 1/3 on basal bolus, most are C-peptide positive. So the islet autotransplant is one thing I'm very proud of, that this arose out of our program here and is now being used at many centers around the world. Islet autografts are highly successful in establishing euglycemia with or without exogenous insulin. They're more durable than islet allografts. Pain relief therapy for chronic pancreatitis when other measures fail is really now the most important, even though originally we were interested in the biology of it compared to islet allografts. Obviously, we've got a treatment for diabetes that is very definitive. It's a standard for what could be achieved with islet allografts with immune response controlled in a non-diabetogenic fashion. Well, this is just a very quick overview of the highlights. There are many, many, many to acknowledge. I really cannot do it all here. I think you know who you are. And again, I accept this Medawar Prize on behalf of all the collaborators. And I apologize for not being able, because of health reasons, to travel to Berlin for the presentation. But thank you again for your attention.